Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, and today, who should get the COVID vaccine this fall? Dr. Fiona Havers is an infectious disease physician and an alumna of the Johns Hopkins Bloomberg School of Public Health with deep expert in vaccine policy. At the Centers for Disease Control and Prevention, she led the COVID hospitalization tracking system that informed vaccine recommendations at the CDC. Let's listen.
Dr. Fiona Havers, thank you so much for joining me today on Public Health on Call. How are you doing?
I'm doing okay. It's been a tumultuous week in public health, but I appreciate you having me on the show.
Well, thank you for coming. And I asked you to come to talk about an issue that I know is very much on people's minds, which is COVID vaccination this fall. For a long time at CDC during the pandemic, you worked on the recommendations related to COVID vaccination. Is that right?
Yes, I oversaw COVIDnet, which was a hospitalization tracking system that looked at who was getting hospitalized for COVID and their characteristics. And that data was used to inform who should be recommended for getting COVID vaccines.
And one of the important points here is that when the vaccine was approved, there was a whole bunch of data about how well it worked right at the beginning for people who had never had COVID. But now most people have had COVID, so it's a somewhat different question about whether vaccination makes sense.
It is a different question. And I think at the beginning of the pandemic, there was no population level immunity. Nobody had antibodies to COVID. Now, basically everyone does. We've had antibody studies that show almost everyone has been infected with COVID or they've been vaccinated. And so the epidemiology has really changed, and the risk factors for severe illness for COVID has changed over time.
So tell me what you saw as the years went by about who was being hospitalized.
So at the beginning of the pandemic, we saw all ages being at risk. Generally speaking, the hardest hit group consistently have been older adults. But at the beginning of the pandemic, there were also a lot of healthy young people that were also being hospitalized for COVID. I think everyone was at risk, and we saw a lot of severe infections in healthcare workers and other people, even without underlying medical conditions. But over time, the epidemiology has changed and really shifted, where now the vast majority of hospitalizations are in older adults. And also very young children, babies and children less than 2 are also still at high risk of being hospitalized for COVID. And in part because they're naive, like they've not had COVID before. And so that's how we've kind of seen the epidemiology settle out.
So if I'm hearing you correctly, people who are older, even if they've had COVID, they're still susceptible to severe infection. And then you've got the babies who've never even had COVID. That's now another group that's really emerged as the pandemic has evolved.
Yes, absolutely. And in the middle, I think people are still at risk if you're an older child or a younger adult who has an underlying medical condition. In those age groups, those are the people we're seeing hospitalized for COVID.
So avoiding hospitalization seems like a good idea. There are a lot of people who are also worried about long COVID. And how do you think the evidence has shaken out about the experience of long COVID several years into the pandemic and its relationship to vaccination?
Yeah, that's a really excellent question. And long COVID is something that's really hard to study. It's not totally my area of expertise, but what I will say is that I think one's risk of long COVID was much higher at the beginning of the pandemic when, again, you had no antibodies to COVID and your first infection with COVID had this risk of having this sort of immunologic reaction that could lead to long COVID. So I think that the risk of long COVID has not gone away, and I think that vaccines likely protect against it if you're currently get infected with COVID. But I think that is less of a problem than it was at the beginning of the pandemic. It's hard to study.
So let's get to the recommendations. Who do you think should be vaccinated against COVID this fall?
So no question, older adults need to be vaccinated. Everyone 65 and older is at very high risk for being hospitalized, even if they're relatively healthy. I also think that there's really strong evidence that very young children, less than 2, should also be vaccinated with their primary vaccination series. So the recommendation that I would say is that for vaccine-eligible children who are 6 months and above, getting a primary series will protect them because the hospitalization rates in that group is still very high. The other group that's really important is pregnant women. I think the hospitalization rates in infants less than 6 months are the same as people who are ages 65 to 74. So a lot of babies are still getting hospitalized for COVID. And the only way to protect the very young infants is through maternal antibodies, either through the antibodies that the mom has already, but those are strengthened when the pregnant woman gets vaccinated. So I think those would be easily by age group, the groups that should be vaccinated and by pregnancy status.
Got it. So your top three groups, everyone over 65, infants 6 months and older for their primary series, and people who are pregnant, particularly for their own health, but also the health of their babies.
Yes, so those groups are clear. I also think it is very important for people with underlying medical condition who are older children or younger adults should be vaccinated as well, because it's very clear that there are certain underlying medical conditions that greatly increase the risk of hospitalization and severe COVID.
Which are the ones that are top of mind for you?
If you're immunocompromised, you're getting active cancer treatment, I think that's a really important group, even though it's not totally clear if the vaccines work as well. I think they are effective in that group. People with heart failure, older adults, I think, or cardiac disease are important. I think, honestly, a pretty broad list of underlying medical conditions increases your risk of severe COVID. For children, we presented a lot of data at recent ACIP meetings that showing in older children, underlying medical conditions, including neurologic disorders, which is not a group that pediatricians necessarily think of or people necessarily think of, but kids with like cerebral palsy or other groups where they have impaired airway clearance have very high rates of hospitalization for COVID. We also just recently published a study that showed that among Black children who are getting hospitalized for COVID recently, I think something in the ballpark of 10 or 12% has sickle cell disease. That is a group that is extremely high risk for severe disease. So in older children with underlying medical conditions should be vaccinated for sure.
This is where we say it's a good idea if you have a question to talk to your own healthcare provider.
Yes. The list is very broad for a reason. And I generally think there was going to be a move to sort of narrow recommendations. Previously CDC had said everyone should get a booster every year, but vaccination rates were low, particularly among kids. And I think there was a thought that it wasn't bad for everyone to get a vaccine every year. But by having more targeted recommendations and being very clear that these are the groups that are really high risk, we could hopefully increase the vaccination rates in those groups. But that's still a pretty broad list. So there, I think talking to your healthcare provider would be good. But I think in general, having a low threshold if you have an underlying condition to be vaccinated is good. And also, vaccines are safe, they're effective, even if you don't have an underlying medical condition.
I hear you saying that the vaccine is still safe and effective for others.
Yes, 100%. It definitely is.
Let me ask you a little bit more about effectiveness, because I think people have questions about, well, I've had COVID a couple times. Is another dose really going to help me? What is the evidence that that is actually true?
I think COVID vaccines aren't as effective as we would like for preventing infection, but it is still continued to be effective in reducing the risk for hospitalization and severe disease. That evidence is very clear. CDC has a number of platforms that track vaccine effectiveness, and it does reduce one's risk of hospitalization significantly, particularly in groups that are at high risk for hospitalization. I think the main goal of vaccines is to reduce severe disease. I do also think that it probably does attenuate illness, meaning if you are going to get infected, if you have been recently vaccinated, you're going to feel sick for a shorter period of time, and you are less likely to be severely ill, so you can get back to work sooner and other things. So I think there is decent evidence that it does attenuate illness, and if you get infected with COVID, you're less likely to be sick for long. I would rather not be out of work for a week when I get COVID. If I've been recently vaccinated, the odds of that go down.
And when you say the odds of that go down, that's based on studies that are recent, or is that based on studies from the beginning of the pandemic?
That's still being tracked. The most common form of vaccine effectiveness study is called a test negative design. And basically, they look at people who are hospitalized for respiratory diseases, and then they test them and whether or not they have COVID or not. And so these are all people with sort of similar characteristics, with sort of similar healthcare seeking behavior who are hospitalized for respiratory viruses. And then they test which respiratory viruses they have. They look to see, and if you have COVID, you're a case, and if you have something else, you're a control. And then they look at the vaccination status. So they see that a higher proportion of people who are hospitalized for another respiratory virus were vaccinated for COVID than those that weren't. And you can do an odds ratio and calculate the reduction in odds for being hospitalized for COVID.
Got it. So somebody who is vaccinated against COVID is going to be more likely to show up with influenza in the hospital than COVID.
Yes. Usually they exclude people with influenza because there's often like confounders with like vaccination status, that people who are getting vaccinated for influenza also get vaccinated for COVID. So, but this is a basic vaccine effectiveness study design that's pretty commonly used to calculate vaccine effectiveness. This is not what I worked on at CDC, but I have done vaccine effectiveness studies in the past. And the vaccine effectiveness platforms track vaccine effectiveness for COVID and for flu and for RSV now as well over time and are updated every year.
Now, ordinarily, these are the kind of data that would be presented to the Advisory Committee on Immunization Practices before recommendations are made.
Yes. And they were. There was a lot of public information that was presented at the June meeting that happened. And I think many people at CDC really wanted that data to be presented, so that those data were out there for the public to see.
And what is your level of confidence that the data will be included in the decision-making coming up?
I have no confidence in that. I think that people that they put in place on the ACIP committee have shown that they have a clear bias against vaccines, particularly against mRNA COVID vaccines. And they also, based on the questions that they were asking at the public ACIP meeting, showed a very poor understanding of epidemiology and methodology.
So the potential here is a divergence between what you're recommending based on the data you're familiar with and what might be the CDC policy.
Yeah, I will say, the American Academy of Pediatrics has already come out with their recommendations. They are recommending the primary series for children 6 to 23 months, and then for older children who have underlying medical conditions. ACOG, the American College of Obstetrics and Gynecology, has come out saying that pregnant women should receive the COVID vaccine. However, not only with ACIP, but with the licensure that FDA is doing, I think that it might be an off-label prescription for a pediatrician to prescribe a healthy baby, a healthy infant who's 6, 7 months old, to receive that, because they are currently only licensed for people with underlying medical conditions who are less than 65 years old, which is a huge problem.
So as we see a divergence between what you're saying, and as you're pointing out, not just you, but the Academy of Pediatrics, the Academy of Obstetrics and Gynecology, then we're going to have really an unprecedented moment where what health professionals are recommending is not necessarily what people can actually get.
I mean, it's already happening. There are pregnant women. There's a lawsuit from the American Academy of Pediatrics and IDSA and all these other professional societies against HHS. And their plaintiffs are like a pregnant healthcare worker that wanted to get the COVID vaccine, but she was refused by the pharmacist because RFK Jr. had announced on X that CDC no longer recommended COVID vaccines for pregnant women. So I think there's already restricted access for certain groups because of the confusion and around vaccines and because of the interference that has been going on with the vaccine policy recommendations.
Well, I appreciate your coming to talk to us about what you think the recommendation should be. And we're going to be watching as CDC does make its recommendations known. And what happens next will be something that is going to be very important for public health. Thank you very much, Dr. Havers.
Oh, well, thank you very much for having me on the show.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.